We don't have yet the hybrid now ongoing.
I think the future is hybrid procedures. I think for sure to be able to combine open and endo strategies.
Okay.
Well, and let me follow you because ah, yes, my first name is Luis. Fantastic. Everything ready. Okay, let me put this here.
No. Okay, let me introduce. This is the head nerd of the.
Nice to meet you. Nice to meet you.
I have two boss there and here.
Okay, nice, good. She's the boss. You are the boss. Congratulations. Yes, I'm doing.
เขามีแว่นตากับเขามีหอก You have your own.
Yes, I have my own. Okay, and okay, thank you. Okay.
So tomorrow you go to Sivaran Hospital. It's the biggest in Thailand.
Wow, in Thailand. Thank you.
You start with
7, please.
No, I mean the shape.
6, yes, 6. I was talking about the gloves. 7, no, I mean the sheath. Yes, 6, always 6. Thank you.
เป็นเซียวอะไรครับขาขวาทำ PTA ขาขวาคอร์ดโอเวอร์จากซ้ายครับ
This is the patient that you will treat.
Yeah, I treat
The left.
This left leg already.
You did antegrade.
Yes, yes.
So this iliac should be okay.
No, I think plan to do the below first, and the second I will treat
Go up.
And upper side.
I can't feel the pulse. Is it stereo? Is it stereo?
Yes, sir.
Oh, nice. This is stent.
Maybe a crossover. I can't remember.
Can I do a Doppler just to understand if there is flow or not? Yes, there is a very nice flow. Good, okay. We can puncture in the stent. Sorry.
อันนี้เป็นอะไรนะเป็นดม Okay. So I need she put on the general anesthesia.
Okay. Okay. Give me that water, please. Okay.
สีเหลืองฟูใช่ไหมครับใช่ครับโอเคสีฟ้า subtraction แล้วก็
Can I check with the X-rays?
โอเคเดี๋ยวฟูเข้ามาเลยนะ
So change this. Yes, thank you.
สเตอร์ไลน์นี่ไหมครับอันนี้สเตอร์ไลน์แล้วค่ะไม่เป็นไรครับ
I wash my foot. I was expecting to do it. I was expecting. Usually it happens. So always the left one.
Okay, เอาอันนี้ต่ำสุดได้ไหมครับต่ำสุดแล้วใช่ไหม
You can.
ขอเตียงขึ้นอีกหน่อยจ้ะ
Yes. Just waiting a little bit. Okay, it's enough.
พอแล้วครับ
Can I move the table? Yes, nice. That's super stand. Nice. I can go up and down.
มูฟลงล่างยังไงนะครับกดลงล่างเหรอใช่จะมูฟลงล่างสไลด์ลงล่างใช่ครับเดี๋ยวเอาปูขึ้นศีรษะ
Okay. No, I want to go.
เดี๋ยวอย่าเพิ่ง
สุดแล้ว
อ๋อ
อันนี้สุดเลยใช่สุดแล้วอาจารย์สุดแล้ว
อ๋อโอเค
Okay, no problem. So we put the super stand. Okay, here we are. let's just put the sheet. It's not block the sheet. Okay, it's done. Okay. So that's saline.
Heparin
5,000.
5,000 นะครับ
Which other stent do you have? Down. That's not superior.
I think this is superior.
Superior is from the iliac into the proximal SFA, and the second one in the SFA.
Second one I think Innova.
Innova.
I'm not sure.
The superior performed very, very nice in a proper way in the SFA, in the common. In fact, I punctured, there was a very big blood flow there. Very good. So, heparin, the guide wire and a catheter to go in aorta and to check. That's 5,000.
5,000.
I inject everything.
Yeah.
Okay.
โอ้ยอย่าเพิ่งนะผมให้ละไม่เอาแล้วนะครับหัวเตียงไม่ต้องให้แล้วนะครับ
I did a cross. Now come on, give me however a catheter, we check through the aorta if there is some lesion in the common iliac. I think we have an stent in the left common iliac. So Abigail is here. Abigail? No. If you want to transmit the case, maybe we can say hello and introduce the case.
Okay.
So in a way, if we want to record,
โอเคได้เดี๋ยวจะอันนี้เล็กพอร์ดอยู่หรือเปล่า
you don't have the microphone. Ask for microphone.
มีไมโครโฟนหรือไม่มีแล้วนะพูดก็ได้ยินอยู่ใช่ไหมโอเค
I put close to you.
Okay, hello everybody. We going to do the case. This case is a female, 45 years old. She got the wound both sides after CABG, and from the physical examination and the CTA shown the lesion at the iliac, fempop and BTK lesion. So now we are going to do on the right side from crossover from the left side. Okay, by Dr. Karina from Albano, Italy.
Good morning to everybody. Thank you for the introduction. So she's a patient that you already treat in the left side, and now we must to check the iliac arteries and the right. The right leg, the right SFA and POP and BTK. So there is just to show you, there is a superior stent in the left side that will go through from the external iliac artery into the common femoral and into the proximal superficial femoral artery. That is still patterned with very nice flow. We did the access through the superior stent. This is a very nice stent to use when we need in common femoral because allow us even to puncture in a game. So here, the right.
Yes, the DSA.
This is a check through the aorta. It's a very small aorta. Seems to have some lesion in the common iliac. So let me maybe to reduce it with putting down the catheter in this way. Okay.
You would like to stop breathing during you inject?
If you want, yes, I cannot communicate in Thailand, but if you ask the patient, well, if the patient is under general anesthesia, okay.
can hold ฝากแอปเนียหน่อยนะครับ
Let me know.
แอปเนียหรือยังนะฮะโอเคโอเค
It was Salim. Sorry, that was my fault. Repeat suddenly. Well,
เลิกครับเลิก
no, common iliac artery presents some plaques, but it seems patent, even if it's a little bit smaller than the external one. The problem here is again in the common femoral. Look, there's a stenosis there. A calcified stenosis in the common femoral. So, do you have some catheters to do the crossover in the way we...
use the ring catheter
Yes, every catheter you have. So, decide to go in a crossover was correct, because there is a lesion in the common femoral that we will treat for sure. Which suprastem do you put in the contralateral axis? Is it 5 or 6? That's probably 5.
no I think 6
6.
เอาวางก่อนเนาะ
So we are preparing everything to do the crossover. Okay, the gateway is in aorta. Okay, I have it.
ขอริมครับ
Yes, yes. I use a similar catheter that we call UF.
UF form
As similar, very similar.
the company
And the company, I don't know which company, Cordis, I believe, maybe. Okay, here we are. Internal iliac. Seems patent. I don't know what happened there. Or I am in a collateral still. Yes, probably. Phew. Hmm. I think so. I think I'm in a collateral because otherwise I cannot explain why I cannot go down. With the left hand it's a little bit difficult, yes. So let me do it this way. Let me remove, do a check. Can we do an oblique?
Right?
Yes, or left, one of the both.
20
That's contrast. Okay. Yes, I'm in the internal iliac from the beginning. In fact, the external iliac was big. Okay, nice. Let me wash and retrieve a little bit. In fact, the way of the guidewire mimics the gluteal artery, and it was. Okay, now it's done. Well, in the calcifications of the common, I think we can repeat the check here. Can we oblique in the opposite side? So that's saline. No fluid. Ah, yes. Push with power. Well, very calcified arteries for this lady. Yes, that's the lesion of the colon, and all this face seems diseased. Oh, sorry. Multiple lesions in the SFA. Good. So, yes, perfect. The pop, this LSFI pop and the proximal tibials. it's not so bad. There's an anterior tibial, there's a peroneal, and a diseased posterior tibial. No, sorry, I took the wrong. We don't arrive to study the foot. Okay, we will. Yes, sure. Wait a second. We do this and then we move. So anterior tibial, nice. Peroneal, acceptable. Posterior tibial, just a proximal diseased. Okay, let's check the foot. Oblique a little bit in our way. Perfect. So that's contrast. Okay. The last angel, just to check the foot arteries. Yes, seems to be in the proper way. Well, there should be a little delay. Look, pedal artery, distal posterior and lateral plantar. Yes, the foot can be acceptable in this way. Remember that we are in crossover, so it will be a little bit difficult to arrive in the foot, but we have a lot of things to do in the SFA pop and the proximal PT. She has lesions in which toe? No, in the calca. So, okay, posterior tibial is our target for sure. SFA and pop. Okay, so do you have a 6 French long sheath? Destination, fantastic. And this is a stiff, tremo stiff. Do you want to put a tremo stiff? Okay, go a little bit up. Perfect.
It's a versatile from abroad. You have to use abroad today.
I use everything you give me.
Oh, wow.
Supracore.
Yeah, supracore. What the versatile is the same family.
Yes. Well done. Okay, let me change the sheath. So we put a 6 French long sheath destination to stabilize our axis on our crossover, arriving in the common femoral artery in the opposite, in the contralateral common femoral artery. Okay. The sheath is going without any problem. We pass the common femoral and we enter in the SFA. So let the gate wire there. Give me a full French catheter, multi-purpose, vertebral, better. We already crossed the SFA till the medium part, so we'll try to maintain this gate wire in place. We will go down with the 4 French or 5 French catheter, and if we successfully cross all the SFA with this gate wire straight, well done. Otherwise we will change for an 040 for an 018 gate wire. And then we will continue engaging the PT, posterior tibial. We will do the angioplasty of posterior tibial, SFA, POP and SFA. Well, usually from below, from below to above, because the first thing I usually try to do is to put the gate wire in my distal target vessel. So before to start to predilate, I want at least to try to put the gate wire in posterior tibial. For sure, if I fail, I will also predilate or dilate SFA and POP. But before than everything, I prefer to put my gate wire in the posterior tibia. Consider if if we cross the SFA and POP with the 4 French catheter and we put a gate wire in the posterior tibia, all the L14 platform balloons will cross and arrive in the posterior tibia. Okay? Yes. Let me help you. No me enganche. Thank you. Here we are, that's our catheter. Let the gate wire advance. Okay. I was hoping to go there, but maybe now that's very big. So let me do it this way, remove it, let me do a super selective injection. May I ask you to go oblique in this way? Okay. Can I have a magnification?
Okay, Max.
Sorry. Good. Perfect. Thank you. can I do a DSL with magnification?
เอ๊ะถ้าแม็กนี่ดีเซลไม่ได้เหรอจะขยายจะดีจะฉีดสีด้วย
Yes, well, perfect. Okay, so we have stenosis in the TP trunk. So may I ask an command yes, guide wire?
Command สีครับ
Release the cameras. Bye. Nothing happened. Nothing happened. It was just a pay attention. Well, we're in a very good place. We are already succeed to cross all the SFA and POP stenosis and lesions. We must manage the TP trunk and the posterior tibial. There is a short occlusion of posterior tibial and a very huge stenosis, big stenosis in the TP trunk.
The posterior is quite far from the axis.
It is. It is. So, possible, yes, it's possible. It's more challenging. You know, torque the guide wire, torqueability and pushability is completely different in crossover compared to antegrade. That's the reason why every time we can, we do antegrade. But today, the solution in the common femoral justify the crossover. Otherwise, if we fail, what we can do is to manage, well, manage retrogradely, I don't think so is possible because the user is close to the vessel way. Let me do a tip of the guide wire. Yes, here, thank you. Otherwise, what we can do today to manage distal and common femoral is to fix the common femoral today and schedule the patient again next week to do the distal. But I think, or at least we will try. I think we have a chance to manage the distality even through the crossover.
ปรับเลื่อนนี่เข้ามาอีกนิดนึง
Oh yes, it will be nice. So the F14 crossed suddenly the TP trunk. You saw how we fell. Fantastic. May I have the reference images that we had previous?
ที่ DSM เมื่อกี้ครับเอาขึ้นฝั่งนี้แกะแต่เอาเป็น reference เอาไว้ฝั่งนี้
Thank you so much. May I have a torque? What happened? It's big. Oh, I think you can try. Yes, we usually use even this big. If it's for 8, no, it's for 35. Because I engage the collateral in the proximal TP trunk. And I don't have any chance to torque the guide wire. Yes, after the stenosis I engage the collateral in the TP trunk, so I need something to torque the guide wire.
ได้ยังครับ
Yes, nice. Yeah, sorry. That's the challenges with the contralateral approach. Even if I torque, the guide wire continues going in the same way.
You think this is a posterior or just the
No, I think I'm in a collateral before to cross all the tibioperoneal trunk. After the stenosis, we are engaged in the tibioperoneal trunk but not crossing. In front of the stenosis there is a collateral and I'm engaging, yes, except now, did. That's peroneal and okay, that's peroneal. Let me try to go a little bit down with the catheter, because now the catheter could help me. If it cross, could help me to change direction. Pull a little bit to get wire. Perfect. Still difficulties for the catheter to cross the stenosis of tibioperoneal trunk. Okay. What we can do now is to check. Now I lose it. Yes, I come back. We can change for a balloon in the way to pre-dilate the tibioperoneal trunk and then try through the balloon to engage posterior tibial. In the meantime, I will light the guide wire in the peroneal artery. So, can we have a 2 mm Armada balloon? 2 mm, 2 centimeters.
220 ครับ
I left you. Okay. No, it's okay. It was just to wash the sheath. Trying to avoid to wash my foot. Yes, I continue washing my foot. No, don't worry. Don't take care about that. It's normal for me. I every day wash my foot. So we are so close to engage the posterior tibial. Just need to change a little bit the direction. But we successfully crossed the tibioperoneal trunk. Now we will cross the peroneal trunk, the tibioperoneal trunk with the balloon, and we will try through the balloon to engage posterior tibial. If we fail, we at least have the chance to remove the guide wire and improve the curve. In the way to help the guide wire.
The catheter is not follow the wire because
The 4 French catheter was not followed because there are many lesions in the SFA and POP, and the lesion in the tibioperoneal trunk is very tough, yes. And let me help you. Start the balloon. Okay, nice. Perfect. So our balloon passed without any problem. May I have a magnification again? Zooming. Perfect. Okay. Thank you. Now the tip of the balloon is a little bit down. Okay, now let me change the tip of the guide wire. We will engage the posterior tibia without problems, I think, and I hope. The fantastic thing of common is that it's not in the wire, so it became straight again.
Okay.
So you must perform the tip again if needed. This allows us to use the gate wire multiple times during the procedure, but sometimes need to repeat the tip. Okay. I did a double curve tip, like a renal catheter, in the way to facilitate the guide wire to go in the posterior tibia. Thank you. Here we are, and here we are, posterior tibial. Now the curve is too much. Continuous engagement. There is no collateral there. Yes, there is a collateral.
Okay.
When you need to go straight, use something straight. We did. We will enter in the distal part of posterior tibia. Look, the guide wire navigating, and that's a collateral again.
You kidding me?
Can we go down? Let me check through the balloon the plantar arteries. Because yes, that's true. We need the calcaneal region and the Achilles tendon area. But if we, let me see how much I can go. But if we also improve the distal runoff, maybe the patency rate of this vessel could be better. There is some collateral or some stenosis there. Yes, please. The torque. Now I continue engaging the collateral. Okay, that's good.
Is that the feeling or you have?
Yes, it's the feeling. Is sometimes looking at the calcifications, knowing the anatomy, a couple of things. Down a little bit more. Okay, perfect. Perfect. Okay, I think we can stop here. We have a couple of curves there, and we can inject through this. So a little bit more down, please, to have the foot. Okay, perfect. We can reduce a little bit the zoom and oblique. Perfect. So fantastic. Oblique a little bit. That's good. Perfect. So correction criteria to identify foot arteries is lateral view to identify the base of the fifth. That's the reason why I insist, because what we will see, we will be able to identify. Sorry, I failed. Well, it seems to have a very nice outflow. We have a spasm in front of the tip of the balloon. So I think we can inject nitrate, small dose, to resolve this spasm. I think we don't need to do anything else in this foot. So just put the guide wire distally and dilate with a 2.5. Pre-dilate with this 2, dilate with a 2.5 posterior tibial, maybe 3 tibial trunk, and then 5 SFA on top. Dilate everything and check the common femoral, because maybe there we put the stent. You know, you did in the contralateral one, and the result was nice during the time, so it means that if we put another stent there, probably we will have the same result. Okay, give me the guide wire.
Same.
Yes, the same, please. Okay, now it's straight again, so the curve's down.
It's shapeable.
It's exactly, but since it's not, you know, in the blood at 37 degrees, it come back to the original position. We have nitro. Can we inject it, please, before? Yes, sorry. Because in the way we remove the spasm distally and then stop there.
It's 1 mil 100.
Okay, one and a half, I think is enough. Yes, more than enough. Okay, let's pass the gate wire again. In the meantime, can we prepare 2.5 20 Armada balloon, 2.5 millimeters, 20 centimeters, 200.
Amanda 2.52พี่อันเดิมเรามีนี่โอเค 2.5 ครับ 2
No spasm. Guide wire progress without problems. Let the guide wire there. We don't need to insist. These vessels are healthy. So let me to retrieve a little bit the balloon and to predilate the proximal posterior and the TP trunk. We can start here more or less. Yes. Just like before, open and deflate, so it's a pre-dilatation. The pre-dilatation allows us to remove frictions and to advance with the final balloon angioplasty, and with the long one to do the final angioplasty. When you want. So for sure she is not feeling pain, so you can arrive to 10 without any problem. It's a 2 millimeter balloon. Yes, I think we are seeing. Yes, we are seeing, but it's full of air. Okay, let us do it this way. Deflate, go out with the air, up, out there. Okay, aspirate again. Okay, now inflate. Maybe will be better. Yes, it was. Okay. Open and deflate. Again. I think the balloon will cross without problems because the catheter is more or less the same, so this balloon cross without any problem. However, since we have the balloon in the better way prepare the vessel for a final dilatation, we pre-dilate. Okay, this part is patterned, so let's just to dilate here the TP trunk.
Yeah.
Open 14. Okay, perfect. Deflate, change. We are going to put the 2.5 200. So retrieve. Thank you. Help me.
2.5
A little bit more. Okay, it's out. Go.
2.5 ครับ The shorter one is the 40. It's okay? 2.5 40.
No, the longest one, 2.5. The longest one is 40. You don't have any? Yes, there was a oh. In the other catalog there was another 2.5 20. No, come on, the 2.5. Yes, 12 is okay. 120. Yes. Well, the difference is in the time. I mean, if you have a long balloon, 1 or 2 dilatations, you finish. If you have a shorter one,
I heard you
then nothing changed. No, yes, I said 220, but because I mix between millimeters and centimeters. It's complex to follow me, I know. I'm so sorry. Okay, to hold a little bit the guide wire. Let me show you distally. Okay, let the guide wire advance a little bit. Let the guide wire advance. Okay, perfect. Stop there. Hold. Okay, that's the long balloon. Let everything move together. Okay. What happened? Okay, I think we can more or less start here. Yes, no more. Then we will check. In the meantime, we can start here. 2 minutes of angioplasty. It's the same try. That's long, probably. Yes. Okay, arrived to 8. Well, yes, I think it's good. Consider the anterior tibial. Look, the anterior tibial is not bigger than 2.5 or at least 3 approximately. So 2.5. She's a lady. 2.5 should be enough.
Okay. Maybe faster than the first case.
Well, different. We must treat the SFA and POP, so it will take time. For sure, the first case, we invest more time to crossing the lesions, passing the guide wire, engaging the arch, and going up in a retrograde fashion. Rather than in this case, we will invest more time in the final treatment.
For me, if I need to treat between the iliac top and BTK, sometimes I cannot control the wire when I arrive about the ankle. So sometimes I just move to the
SFA, yes, that's the second strategy. So I mean, if I fail with the crossover, for sure move for the antegrade. But in her,
to the stent.
yes, exactly, like we did. We are through the stent in the contralateral. Puncture the stent. If you do it antegrade or retrograde, nothing changes. You must to puncture the stent. The problem today to do the ipsilateral was the common femoral, and for sure, if we put stent, I don't want to puncture the stent the same day I deploy, because you can move it.
Okay.
So if you put the stent after 2 weeks, the stent is fixed. Exactly. But when you put the stent, after 30 minutes you put the stent, you puncture the stent, you can move it. So you can damage the work you already did. We have time.
Yeah, if we have เท่าไหร่แล้วครับ
Okay.
Okay.
It's close to 2 minutes. Okay. Yes. Thank you. Okay, I think we are not still treating the stenosis in the tibioperoneal trunk. Okay, well done. We'll repeat a little bit down.
Usually my problem when I do it's difficult to cross the arch. Usually the wire tend to go to the
Metatarsal branches.
Yeah.
It's dependent on the tip.
Of the wire.
If you have a straight tip, the guide wire always goes straight. If you curve the tip, just rotate and the guide wire is obliged to go in the arch.
You just find a way.
Yes. And sometimes change the projection how we did previously help, because in the lateral way you can see that the guide wire through the dorsal go down, but you never know if it's going in the proper way. So you put the guide wire going down, then do the anteroposterior view, and you can follow the guide wire going into the arch. Knowing the anatomy seems stupid, but it's important, because sometimes feeling is very helpful, but knowing the way you expect your guide wire is important, because you suddenly understand if you are going well or not. Okay, deflate. We will repeat a little bit up to treat the tibioperoneal trunk, because we pre-dilated, but still not final dilatation was done. Dilating this way. That's the lesion. Yes, try to write to 8 and 10 to.
10.
Okay, perfect. So now 2 minutes. In the meantime, can we prepare 5 millimeters? Yes, I think 5 for poplite and SFA should be good. Or we want to start with the 4. What do you think? The SFA I think is big. We're able to identify the calcium. 5. You have a 5 long one. Even 018, if you have an Armada 18, is good.
In some case that I want to open, I want to open the tibial trunk. I want to keep the anterior tibia. And sometimes when
Well, I understand what we are talking about. So to protect the anterior tibial to don't have plaque shift.
necessary or
It's depend. We didn't protect the bifurcation between posterior and peroneal because seems to don't have lesions there, and the same in the ostium of AT. The ostium of AT is bigger than the balloon, so probably this balloon is unable to close this artery. But when you have a disease bifurcation, it's useful to protect it because you risk if there is a plaque in the bifurcation then compromise both osteums. If you have time, it's better to put 2 gate wires. This time seems to have the lesion in the tipi trunk and then in the distal posterior tibial, not in the bifurcations. Okay. So deflate. Let us retrieve the balloon. Can we remove the zoom, please? Zoom out. And we will check all the posterior tibia through the sheath in the way to understand if in some way we improve the flow or not. Okay. Retrieve the balloon, please. We can do it this way, look. We can let the balloon in the SFA in the way if we need to repeat something down. We have still the balloon there. Give me audio, contrast. Well, so diluted, but the posterior tibial seems to functioning well till the distal part. But because we have spasm, probably we have distal spasm. Let me do it this way, in the way to be sure we don't lose. Let me do some here and here. So tibial bifurcations were okay. Probably there was still some stenosis in the distal PT. Maintain a little bit the gate wire. So we will try to dilate all the posterior tibial in the way to improve the flow for the foot. May I have a magnification again, please? Okay, and the torque? Here we are. Yes, please.
I saw Dr. Mancy do.
Probably we have a spasm. Yes, and the vessel was patent, and I engaged in a collateral now without any chance to change the direction of the guide wire. Look, even if I torque, the guide wire never torques. So let me try in this way just to see. No, still in this collateral. Okay, let's start here, dilating in this way. Come on, dilate. At 6, not more than 6. Look, there is a stenosis in the lateral plant. Oh, it was a bubble. Okay, 8. Let me check through the balloon.
Small.
Yes, small seeing with contrast. Yes, the artery is patent there. It seems to have a spasm.
It's a lateral?
It's a lateral one. Give me the guide wire again. Remember that she is very young. She's 45. 55, so not really young, but is young compared to the normal patients we usually have. She's very young, so still reactive arteries that can do spasm. Yes, no chance to torque. Okay. How long was the dilatation?
Yeah, more than 2 minutes.
Let me retrieve a little bit the catheter in the way to understand if in some way I can. Oh, I cross. No, I was convinced. No matter. Shh. The artery doesn't want to let me pass. Yes, no way. will be happy to cross, to be honest, and to dilate a little bit there, because now seems to have a torque, at least. Because I move. Okay. Okay. Yes, but some difficulties to pass, so there is a stenosis there.
Okay.
Now the balloon will cross, look. Yes, fantastic, well done. Okay, now look at 4 atmospheres. 1 minute and a half, 2 minutes. Did the final dilatation of posterior tibial. Enough. Yes, perfect. No more.
ที่เราเพื่อเป็นวิดีโอนะต้องยังไงก่อนนะผมก็ลืมแล้วเมื่อกี้ตอนที่ผมขึ้นบอลลูนทำให้เป็นวิดีโอก่อนทำต้องเหยียบสีดำก่อนใช่ไหม
Can I ask Salim, please, to wash the sheath?
คือปกติถ้ามันไม่ใช่ DSA มันจะไม่บันทึกแต่ว่าถ้าผมอยากได้ภาพวิดีโอเมื่อกี้มันเป็น all frame แบบ all frame เดี๋ยวอาจารย์บอกผมแล้วกันผมกดตรงกลางใช่ไหมฮะก่อนเดี๋ยวบอกผมดีกว่าแต่ต้องทำก่อนที่จริงต้องตั้งค่าไว้ก่อนเดี๋ยวไม่เป็นไรเราทำ
Okay, the sheath seems to don't to go well.
เข็มยาวเลยตั้งแต่ต้นเดือนตันใช่จะมารีคอนประมาณสักวันเตอร์ลงมาได้ใช่
You must retrieve this balloon and to check the sheath in proper way, because it could be full. Yes, the blood is turning away, but very slowly. So deflate there. Put another mat here. Okay. I think we already did the proximal part. Yes, for sure. So we will retrieve the balloon. We'll check the sheath, wash or do everything we need to do in the sheath, and then dilate SFA and pop.
Usually for the iliac lesion, you prefer the bare stent or?
For the iliac lesion, it's depends, but usually move forward with stent. Usually, no cover, no cover stent. Yes, usually bare metal stent. Yes, in a common iliac, usually balloon expandable. In external iliac, usually self-expandable. Yes, bare metal. If I cross subintimally in a CTO, maybe I could put suddenly a cover stent, but what I usually do is to prepare, put in a big sheath for needed. So if I need the cover stent, usually I start to pre-dilate with the balloon. If I succeed to open the artery, I check. If the result is not bad, put a standard mite, you know.
Because I want to try for posterior Covera or something.
Covera.
Okay.
No, I never use. And the only cover stent I have is Fluency, and it's yes, for treat access issues, common femoral or iliacs, or yes, 6 millimeters to put in the SFA. Okay, deflate.
จะใช้ Y14 นะY18 14 command.
Okay, retrieve it. And now the sheath probably skewed. It was the balloon inside giving problems. Okay, move forward with the 5 millimeters balloon.
5 balloon ครับ
We have 150 and 100.
150 and 100. Not the longest, 150. So the sheath seemed good. Look.
It's just the balloon inside.
Yes, probably it was.
ยังเพราะเราต้องไปแค่หลังก่อน
How long have you been working with her? How long? How long have you been working with her?
Just 6
No more than an hour.
for
No, today. How long we have been working till the beginning? An hour.
You can work
No, but I mean, how long? How many minutes we have been working till now? From the beginning? Yes.
อันนี้เราสัมภาษณ์กี่โมงนะ
It's just to know if we need to repeat.
1 hour and 15 minutes.
15. 1 hour. 15. Okay. Do you repeat heparin after 1.5, after 2, or you never repeat heparin?
2
After 2.
but just half dose.
Okay. Yes, sure. Yes. Repeat half dose. Sure. Yes.
รับเลยนะ
Okay. Hold the guide wire.
โฮไว้
Hold the wire. Thank you.
ครับรับเลยพร้อมดีแต่ยังไม่เอาเข้ายังรับไปไว้ที่ waiting room
Hmm.
ไปอีกหน่อยให้น้องดีกว่าที่โจ้
Hold.
เดี๋ยวบอก
This balloon. Find some difficulties to advance. Yes, I want to wire the joint knee, the knee joint, because it was there the last stenosis. Okay, nice. I think we can start here and dilate everything. So this is an Armada 18, 2 millimeters, 150 centimeters. Millimeters, yes.
5
It's 5, yes. What I said 6. 2. I said 2.5. I'm so sorry. It's 5. It's 5. 5. I was not drinking for breakfast. I promise. There was Abigail with me. She can.
4 6
Nominal 8.
Thai
Yes, the knee joint was not
Leg work.
okay it's normal
so impressed. Okay, good. 8. So 1 minute and a half or 2 minutes. I'll repeat everywhere till the common femoral, and then we will check. Common femoral was not an occlusion, it was an stenosis. So just let us check with the balloon.
from the vision you think the SFA need the stent
I don't know if we need the stent. No, it's depend. If it was not an occlusion, it was multiple stenosis. So my practice is, if it is the first treatment for her, Usually I try to avoid stent, and usually I try to gain the lumen with pleural balloon angioplasty. If the result is good, I usually wait and check, or otherwise use a DCB in the lumen.
Just the DCB.
Yes, just the DCB. There was not an occlusion. Different is the common femoral, in which from the beginning I was thinking to put stent, but I want to see the result, because the common femoral is challenging, can be compressed, so if you could dilate, at least the artery could fail for an external compression during flexion leg and so on. But however, for the first treatment in a not occlusive lesions, it worked. So come on, I cross in 1 second. It was a multiple stenosis. And this type of lesions, I think we can do step by step. Consider this: she's young. You will treat her again multiple times during the next, I hope, 20 years or more. If you put stent today, the next time, what we will do? If the stent is occluded, you must treat an occluded stent, and you don't have the chance to put stent again. So in a young patient, never lose the possibilities. If you do everything you have today, what we will do tomorrow? You don't have chance. Instead, if you left her with a balloon, she's back after 6 months for restenosis, you will have the chance of stent, DCB, atherectomy. If you do today balloon and DCB, and she's back in 6 months, what we will do? Put stent, okay, and then no more options. So that's the reason why sometimes we try to save options, because we know we will treat this patient multiple times during their life. Okay, retrieve the balloon. Okay. Okay. Yes, inflate. Look, that's multiple stenosis. For sure, if we obtain a dissected artery, we will consider the option of stent. About the common femoral, you think she's candidate for surgery in the common femoral? No.
Because even she got the CABG, but the heart not quite good. EF เท่าไหร่
She doesn't resist the surgery. So cases with surgery contraindication could be the best candidate for stenting in the common femoral.
เวลาเขาทำเองดูง่ายไปหมดเลย I don't know when the copter or the experts come do the operation, everything is look easy.
Well, yes and no. So I mean, as I said before, you must to train yourself. I mean, there are more than easy. Sometimes it's fear-related situations, or I don't know, but I feel comfortable doing what I do. That's the reason why maybe sometimes for me it's easier than for other guys. But if I do, everyone can do. That's the only thing for sure clear. Can move a little bit up. So I mean, I'm not the special one. I mean, if I do, you can repeat. You must to try. You must to be skilled. Okay. Retrieve. Okay, okay, a little bit less. Okay. Again,
Osteum.
multiple stenosis. Okay, perfect. We will do another one covering the common femoral, and we will check the result. May I ask you to do an oblique in this way?
15 ก็ได้
Okay. In this type of lesion in the SFA, you always think to put stent, because my flow chart is always pre-dilate, dilate the artery and check. I never start thinking I will put a stent. So I mean, if I have a long CTO and I cross subintimally, for sure I think I will put a stent. But in this type of lesions, I always said, okay, pass the balloon and dilate. If the result is acceptable, consider if you really need the stent or not. Retrieve the balloon a little bit more. Okay, enough. Inflate again. Because you know, if your pre-dilatation allow you to do a DCB or to do something else, maybe you can avoid stent. I mean, stent is always an implant, and for sure, if I need, I put supra stent in these cases.
Usually for my practice, when I have the case that the disease confined in the common femoral and after same part of it, I usually do the endarterectomy and go up and go down.
Yes. So you do something hybrid. You open the groin. Yes. I think that's the best approach when you can do it, because you don't have any problem with the axis. You can go up and down in the same axis. You cannot have complications because the groin is open, so you can. And if you have a common femoral disease artery, you can finally correct it.
How often do you need to perform an little gate puncture for the BTK lesion?
It's depending on the cases, but it's more or less 12-15% of cases. Yes, it's not so frequent for pure below the knee. For complex cases, we arrive at 35%.
If possible, you start with, and you show in the morning, start with the anti-gate first.
No, so no, sorry.
I mean, usually practice you start with the anti-gate.
Yes. Instead, cases like this in which you know you must do the crossover. Otherwise, usually start antegradially, as we have been working today. Try to pass. If you fail, try in another way. Again, fail. Okay, think about retrograde puncture. Okay, we did. Okay, remove the balloon, please, and remove all the zooms. Zoom out.
Zoom out. Also the
Okay. If you want to remove the balloon, always maintain there. Let me give me a contrast, please. We will check and we will discuss about if we need. Can I ask you a little bit more oblique?
อีกครับ10 20ครับใส่รอบอีก20
Perfect. It's just to have the common femoral well open. The result is not so bad in the common femoral. I'm continuous washing my foot. Dio santo. A little bit more contrast. Okay, what do you think about the common femoral? Can you reconstruct the images?
stop ให้หน่อยครับ
Seems to have a plaque. There is a plaque clearly.
Yes exactly because from this ครับอีกไปเดินหน้าอีกนิดนึงถอยหลังโทษทีถอยหลังโอเคพอครับ I think the part may be around here
Sorry, I think we have still a residual stenosis here.
okay
Here we have the ostium of the SFA, and I don't think so. That's something important there. Maybe a flap, but it's a linear dissection. If you remember before, we saw profunda, and the SFA was very slow. Now we cannot see the profunda in a proper way because all the flow go in the SFA. So from the hemodynamical point of view, the result is good. From the morphological point of view, we still have some residual stenosis in the place in which we saw the stenosis from the beginning in the common femur. There's a linear dissection. Again, not flow limiting ones. I usually don't stent this type of dissection. What we can do is to repeat the angioplasty there and repeat the common femoral with the 6 mm balloon. Let me check distally. Yes, thank you. Poplita is perfect, and the tibial arteries, all 3 tibial arteries are moving down in the same way. Okay. Just to check, it's a second. Just to check posterior tibial, I will retrieve a little bit the gate wire in the way to don't compromise the flow for the gate wire inside. Here we are, 3 tibials. There is a spasm in the anterior tibial. Look, we never touch. We have a huge flow, a big flow, that the contrast creates a spasm in the anterior tibial. So I think, from the hemodynamical point of view, I think the result is nice. From the morphological one, we can repeat the angioplasty in the proximal medial SFA with the same balloon, the 5 one, and we can use 6 in the common femoral. Look, there is a very good blush in the wound area. And check again. If needed, we put stent in the common femoral. Yes, look the blush, fantastic, very good. This is the blush. There is microcirculation that remain before veins.
is a deep plantar arch or no
Which? This is the deep arch. Yes, this is the deep arch between median plantar and lateral tarsal. Okay, so put the same balloon again, the 5. Repeat another 2 or 3 minutes in the SFA. And prepare a 6 mm 4 cm balloon, 640 for the common femoral, or 660 or 640 is the same. That's very nice. The result below the knee is very nice. We have a lot of spasm there. Okay, thank you. Hold the guide wire. You can retrieve a little bit the guide wire if you want. Okay, fantastic. Very good. In the way to avoid new spasm in the tibials. Okay, I think we are close to the area. You must repeat the dilatation. Okay, we can do 2 dilatations here and then a little bit up. Right to 6 and maintain at 6. Yes, if we have a dissection, what we want is not to oversize the artery, just to allow the dissection just to reduce this dissection, to close. So a low pressure usually allow us just to compress the dissection without oversize, because if you use more pressure you can still dissect the artery, increase the dissection. Instead, low pressure usually give us better result. 3 minutes. Again, okay. Okay. It's your case. I will help you. You will do.
Okay. I failed to this case.
Okay. I will support you. You cannot fail 3 times. You cannot.
And if you fail, I will bring her to the bypass.
Come on.
Not bypass. Not.
Venous bypass. Okay. Well, venous bypass.
She don't have the runoff.
She doesn't have runoff.
In the artery. It's
Yes. Okay. Okay. It's so calcified. Okay. Let's check. Let's see. You know, there are still limits for endovascular approach, and the patient that has the option of a distal bypass, why not? I mean, if you fail twice, why not? And which kind of bypass are you thinking to do? I mean, if there is no runoff, there is no runoff.
Yeah, I plan to do the fem posterior tibial vein bypass.
In vein. Doing a vein arterialization. Okay. Plus valvulotomy. Plus valvulotomy of the foot veins.
Yes.
Okay.
With
Percutaneous valvulotomy. Well, yes, for no option patients, that seems to be a new option. It was 3 minutes. Okay, deflate. Let me repeat in the proximal SFA again. We will do it this way. We will repeat again, dilating again the common femoral. Again at 6 or at 8. Okay. Okay, nice. Another 3 minutes. Then we will check again and we'll prepare the 6 millimeters for the common femoral.
TPO ก็มี DBT ด้วยผู้ชายอายุ27 ปียังไม่ทำอะไรเลยก็จะจบจะว่าเจ็ตสตรีมันเดือดเลย
เดี๋ยวดูอาจจะใช้อันนี้ดูแบบไม่เวิร์กว่าเทสติ้ง
เจ็ตสตรีมันต้องรีบเขียนจดหมายขอเขาเองต้องใช้ไว
Are you hungry?
No, I'm okay. To be honest, I'm okay. I'm feeling a little bit back pain, but it's because I stayed up for a long
We
time.
will have lunch before we move to the
Okay.
third case.
No spicy lunch. No spice. No, no, no. It's Japanese. Thank you.
Japanese.
Oh. This evening, everything will happen this evening.
This evening, the same view.
Yes,
You just move 10
a little bit more.
different different test.
But I think that this evening you should try the real time.
Yes, thank you. Thank you. Okay, 3 minutes done. Two, just two. The time is very slow in Thailand. Move forward very slow.
Usually, what time you work? I mean, the last when you finish.
When I finish, it's dependent on the number of patients, but usually between 5 and 6 o'clock in the evening.
About 5 cases
Yes,
a day.
yes. And when I, for example, when I have a train or a flight to go other ways, we have 2 cath labs. So sometimes I'm able to do 5 patients, yeah, and finish at 2 o'clock in the evening. Lose every stop because you prepare a patient when you are in the middle, prepare the other cath lab, finish, close, wrote the inform, and start in the other cath lab. So sometimes in 3 hours you do 2 patients. That's good when you must to go. Okay, retrieve. We'll check again and we will decide. Well, the SFA is better for sure. We really identify now 2 linear dissections that for sure do not limit the flow. About the common, I think we still have this residual stenosis. So put the 6 millimeters balloon and do 3 minutes angioplasty and then check.
640.
640 is good. It's raining again.
Yeah.
Yeah.
Raining season. ไม่ใช่ไหมหน้าฝน
ใกล้แล้ว
การ640นะคะ
ครับ
มันได้18นะคะ
เ
Okay. Hold the guide wire. Okay, I think it's enough in this way. Can I have a zoom? Zoom in. Okay. And now, what happened? Oh, dumb. Okay, inflate it. I think we can arrive to 6. No more. It seems to don't have a waist, so seems that maybe it's another position of some branch of the profunda rather than a residual stenosis, because the balloon opened very well without problems. Well, if you need suprastent in the common femoral, how you place it? I mean, how? I mean, you place the stent only in common femoral, from common to the profunda, from common to the SFA.
I did the few cases from the SFA up to the external.
Okay.
Yeah.
I think if you have a long lesion, this is the best place to do, because you guarantee a direct blood flow in the SFA. And related to the type of the stent, there should be no problem with profunda. When I usually do in this way too, from the SFA into the external iliac. So cover all the common femur. In fact, if we need here, I was thinking to put a 5 millimeters, 10 centimeters, or 8 centimeters super stent to cover the ostium of the SFA till the external iliac.
ถ้า6มิลได้กี่เซน
6 มิลของ
ซุปหน้าใช่6มิลแล้ว
ใช่ค่ะ
ประมาณมีได้จับหรือเปล่านะจับ
จับค่ะ
We forgot
To put the time, we are close to 2 minutes. We are so close, guys.
ลืมไงคนจับลืม
It happened. It happened. Okay, deflate. It was 2 minutes, quite sure. Remove the balloon. No push the guide wire. Don't push the guide wire, because we will have a spasm in the distal arteries. Okay, perfect. It's a branch of the profunda. It's the branch of the profunda. Look again. It's the origin of the profunda. Can we angulate in the contralateral way?
มาด้านนี้ครับสัก20แล้วเนี่ยลองดู
The flow is so nice. Can't be there stenosis. Give me contrast, please, again. Is the ostium of profunda. The common femoral is skewed. The problem is the ostium of profunda that is stenotic, and the ostium of the SFA have dissection. but the common is perfect. Probably the problem from the beginning was not in the common, rather than in the ostium of the SFA, in both ostiums. So there is a dissection there. It seems to do not limit the flow, because the flow is fast, is skewed, but there is still a dissection there. I don't know. I usually, from my perspective point of view, I usually wait and check how it's going. But if you want, because you know the patient better than me, if you want to put stent now, we can put the stent now. We cover the ostium of profunda, we put the stent from here to here, more or less, yes. As you prefer. I usually wait, but if you prefer to put stent, we go down again with the 6, pre-dilate at 6, and put a 5. If I put super stent there, yes. If I put
we can control the.
I hope. I said from the beginning I will cover the ostium of profunda, so I will choose a longer stent. The lesion should be 4 centimeters, no more. Look, if you choose 8, you're sure you cover everything. There is no risk. So we put from here, from here to here.
Patient, he don't want to. Afraid that I want to open the artery long as enough to until the wound.
Well, from this perspective, even if we increase the patency in the SFA, the problem could be with the posterior tibial. So we cannot guarantee, even putting supra stent in the proximal SFA, we cannot guarantee the proper patency for posterior tibial. In fact, so you could have a big flow for 1 month, and then if the posterior tibial is occluded again, still you will have less flow than before. And again, we can cover the ostomy if you want. We do without any problem, but it was a full lesion, a long lesion of this SFA, as you prefer. Now, if you consider that is the best option.
For me, I think because this patient, she don't want to do more intervention.
Hold the guide wire. Yes, sure. You know, the real situation of the patient is yours.
Open the flow as much as possible.
And for as longer as possible. Okay. So you agree, however, to cover only the ostium of the SFA with supra stent. The rest seems good. Okay, we have a supra stent 5 millimeters, 80. Inflate. Arrive to 10 atmospheres.
When you shoot the size of the stent, is the same size of the vessel. Or
Yes, I think the vessel is 5, more or less. We are open at 6 to have enough space to put the supra stent properly. Okay, deflate. Yes. Yes, perfect. Inflate again. Inflate. Okay, deflate. We have the chance to do a road mapping here.
Yeah.
Perfect.
Road map เราฉีดก่อนแล้วค่อยทำใช่ไหมครับผม
Inflate again. Increase the pressure. Increase. 10, 12, 14. Okay, maintain there. Look, that's the ostium of the SFA. Still residual stenosis. Okay, prepare for road mapping. That's contrast. Good. When the stent is ready, we deflate the balloon, do a road mapping, and pass the stent. Okay, the stent is ready. Okay, deflate. Retrieve the balloon. Oh, pay attention to the guide wire, the guide wire. Pull, push, push, push. Okay. Okay, okay. Okay, well done. So, good. Road mapping, please. And
ก่อนหรือยังไงนะครับโอเคครับ
how I can do?
You do the DSF first. Okay.
Yes.
โอเคครับ
Good.
แล้วก็ทำเป็นเอาเหรอ
Pass the stent.
ไม่ถึงว่ายังไงนะฮะกดก่อนฉีดเหรอโอเคจะต้องฝึกเอาข้างนี้ก่อน
It will appear when I will do a fluoroscopy.
Okay, I will do it.
Put the stent in the way we don't have any movement, I hope. Okay.
You apply the black bottom first. Okay. สีบนสีเหลืองถูกไหมครับ
Perfect. I think that's correct in this way. So let the guide wire. Close to me. Okay, thank you. So in the reverse way is my first time. In fact.
You can do it even the left hand.
I'm trying. Okay, can you remove the red mapping because I can't see the stent?
Okay, I'll. Okay.
And give me a magnification, please.
ขยาย
More.
ขยายเข้า
Zooming.
เข้า
Thank you. Okay.
So you know how to arch. Zoom in.
Well, the stent is opening there. The first tracts. The secret with suppressed stent is, as you know, pre-dilate properly and deploy the stent slowly. If you go fast, the stent elongate. If you go low, the stent usually can maintain the proper shape.
You control with.
I try. Unfortunately, I don't have any chance because it's so slippery and because I'm in a contralateral way, in a reverse way more than in a contralateral one. Now it's good. I like. This is the proper imaging of the supera point in both ways of the wall, in both sides.
เราทำให้มันเคลียร์กว่านี้ได้หรือเปล่าไม่ถึงเห็นสเต็มหรือว่าอะไรนะ
Yes, that's good. It's difficult to see, yes, but I passed the worst zone. Look.
Okay.
Let me see a little bit up. Sorry. It's good. That's finishing the last. So in the plaque it remained a little bit compressed even after 6 millimeters pre-dilatation. Now it's the last crown and finish. So retrieve everything, close, remove the sheath, the catheter. So it's good, I think, little bit elongated in the proximal part, so in the distal one where I start, because I wasn't able to see it, and in the plaque. Okay, zoom out, please. Let us check. Okay. Completely different. Even the stenosis, even the dissections were covered. The stenosis in the profunda now is more significative. For sure, we improve. There is still some residual dissections that do not limit the flow distally. If you want to cover it, just put the balloon 6 again and put another supera stent in this part. That's what happens when we start to stent. Then we don't finish. Yes, because for sure, from the morphological point of view, the result with stent is fantastic. So now you don't want the distal dissections.
They have the competitor.
Yeah, exactly.
And tell your brain, no.
No, as you want. If you want to continue,
Just see here.
the knee.
The knee, yeah.
Okay. Give me contrast, please. We are still looking from, yes, this way. It's a dissected artery, for sure.
For me, I want to cover here.
To put stent. Okay, 6 millimeter long balloon. You have a 6 millimeter 10 centimeters balloon. We pre-dilate everything at 6, and then we can put a long supera 520 in the way to correct all these dissections. Why vascular surgeons never accept dissections? Why? Never accept. They are no flow limiting. but for sure I agree. It's a challenging patient, many problems, young one, challenging artery, so calcified. So I cannot say that this is not the proper therapy, the better therapy for her. Probably I just, if she's my patient, I will just wait a little bit to check. But in the other hand, that's true. If the result is not good and she will back, if she is back, you don't want to treat her again. So better to put stent.
Around 35.
Yes, it's okay.
Okay, so you have a 6.
12, 612. So again, road mapping just to decide till which place they dilate or not. No. Magnification, please.
ขยายครับ
Zooming.
Zoom.
Okay, enough. Let's compressing the stent. Però non toccare più. Dai, però. Okay, do you have an awaiting adwire? Or otherwise we can put the O35.
ไม่ใช่28
Command 18. Command 18. Yes. 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 Yes.
จะโชว์คำนี้ว่าอ๋อ เดี๋ยววีใส่คำนาน ES ค่ะ
Oh, to make it moreนี่อันนี้ออกมาแล้ว
ใช่ครับ
ใช่ไหม
ใช่ใช่
อ๋อโอเค
Pass without any problem now. We will post dilate a little bit this proximal part of the supra stent in the way to arrive to obtain a good apposition. Okay, zoom out please. Dio santo, benedetto. Okay. Maintain, hold the guide wires. Okay, I think we can start to predilate at this place. No more. Give me a second. The 18 finishing a collateral. Still going in the collateral. Maintain, hold both gate wires. Because at this point I want to use the 18 to put the super stent. Okay. So start here. Inflate for 30 seconds and deflate. This is 12. Yes, 20 super stents should be okay. Arrive to 10 and 12. Maintain for 30 seconds. Okay, deflate. Inflate again. Another 30 seconds. So we have a super at 5 millimeters, 200. The longest one.
Longest one is 120. 12.
There is no 20. We need another 2 of this.
ไม่มียาว200 no no
Oh, there are another one. We can use 3. So I mean, we can put 2 super stents more, 2 more. She has another 512.
อันนี้เรามีอะไรบ้างมี5คอย
มีหลายอันค่ะอาจารย์
เราไม่มียาวกว่านี้
no no
Okay, okay. No saving time.
Ah, no, I'm so sorry. No, still in tile. Stupid. I'm so sorry.
So we can use 12 too.
Yes, we need to cover. If you want to cover all the dissections, we will need to. We will now do a road mapping after this pre-dilatation, and we will check properly. But probably we will need to. Okay, deflate. Okay, in this way we cannot damage the previous super stent because the sheath is inside. Okay, perfect. So retrieve the balloon and retrieve also the 014 gate wire. We maintain only the 018 one. Okay, okay. Yeah. Okay, this gate wire is out, Thank you. Let's check another road mapping and choose how to move. Okay, it's clear. Small bleeding, nothing happened. Okay, give me the 512. Supra stand. Oh. Chi te l'ha chiesto? Perché hai fatto questo? Che coglione. Ok. Okay, so I think we can start here at this collateral place and go up. With 2 stands should be enough, I hope. Okay, zoom in please. Okay, perfect. Too much. Very calcified artery, even if we predilate at 6, many places we were unable to achieve a good lumen. again another.
You call the calcium or?
No, probably it's related to residual stenosis. Even if I push the catheter, even if I maintain the pressure, the stent is unable to manage the recoiling point. That's the reason why I usually prepare everything, then pre-dilate and put the stent suddenly, because if you have recoiling, not always you can manage. Instead, after pre-dilatation, usually the artery is ready. Well, what happened? There is a difficulty related to the crossover. Probably the catheter have some difficulties to move in the aorta. Because when the catheter was down, I was able to control it. Now I don't control. So I cannot compress. If I compress, the catheter kink, yes, collapse. Look. Even if I decide to use the 18 guide wire, that is the proper guide wire. I will fail for 2 or 3 centimeters, so it was elongated for sure. Do you have another short stand? Can you oblique in this way now, please? 40 I think. Let me check. Well, okay, good. Yes, 40 probably is good, is enough. Rincoglioniti, eh. Yes, 40 is good, is enough. There is a dissection, and we have still some bleeding out here, small bleeding, both points. Even if I was able to compress a little bit the stent there. No, nothing important. Yes, both points of bleeding, but external compression will be enough. Okay, give me the 540 that we overlap both the stents, and we finish here. That could happen with aggressive pre-dilatation.
On the bleeding, we just put the balloon.
No, I think this is
External.
yes.
Maybe here.
There is no hematoma, so it will solve for itself. Che rincoglioniti. Thank you. Here we are with the last one. Tira su. Maintain this, please, because otherwise we risk to lose the gate wire. Okay, that's good. Good enough. Thank you. So we'll try to do a 1 centimeter overlap and another one proximally, just to connect both stents and nothing else.
Like you difficult to control.
Yes, with this sheath. I don't know why, but if I push, look, remain a little bit compressed rather than to open in the proper way. However, it seems good now. Again, it's elongate a little bit. The elongation inside the other stent is normal, because I don't want to compress, because it's reduced too much the lumen. Okay, retrieve. So we will check if zoom out, please. More, a little bit more. Okay, it's out. No, come on, don't worry, I have it. Zoom out, out. Zoom out.
So yeah, it's maximum out.
No in, out. Less bigger.
ไม่ถึงออกนะ
Less.
ออกไม่ได้ก่อนออกจริงก่อน
Okay, no. Okay. It seems good. Seems to don't compromise the profunda. So without zoom, let's check all. Remove all the zoom. It's too big. Remove all the zoom.
ตอนนี้เราไม่ได้ซูมใช่ไหมครับตอนนี้ it's normal
No more. Less. Without zoom. No zoom. It's full of zoom.
ไม่ซูมno.
Less. No zoom.
เอาออกสุดแล้วเหรอ
What happened?
เอาอันนี้ลงอีกได้ไหมเหรอเอาเตียงโอเคเอาเตียง we have
No. Okay, idiot. Okay. Let's to control this place. No, idiot. Okay. Yeah, it's a little bit bleeding, both. Yes, we can try. We have the 6 balloon, pass the balloon and we will open it for a couple of minutes, and the way to try to Aspirate the balloon. No, pay attention to the guide wire, please. Hold the guide wire. Oh, Dios santo. Okay, here we are. Okay, nice. So that's the place. Inflate there. Millimeters. Put the time for 5 minutes. Yes. If at least we fail with 5 minutes angioplasty, we can put the pressure cuff, and inflate it to 40, 60 and maintain for 30 minutes. Instead, the stent is uncompressible, so we cannot compress the stent.
Usually here we have lunch at noon.
Oh. I was doing my best. I advise you to avoid standing. Okay. Okay.
Okay. 5.
5. Okay. Give me a contrast, please. I think we can maintain there. We will discover even with the balloon if there's a bleeding or not. Very small one.
Okay, but it's small.
Distal is not so small. Proximal is small. Distal is a little bit bigger. Repeat again another 5 minutes in this way at 6 atmospheres, no more than 6. And I think we can prepare the pressure cuff to put out.
During the balloon or outside?
Yes, we can put outside with the balloon, then we check without balloon but with the pressure cuff if there is no bleeding. So if the pressure cuff can compress and avoid bleeding, we can maintain for 30 minutes the pressure cuff.
Picture. Pressure cuff ที่เป็นเข้ามาในฟิลด้วย เหมือนออโต้สเตอร์ไลน์ทูนิเก้สเตอร์ไลน์ Maybe because the calcium, I think.
Yes, you know, some places in which we were able to clearly open the artery, and now related to the calcification, very stiff wall, we probably crack the plaques and we create the fissuration, because without flow or with the dissection still in place, without stent, we saw the bleeding but it was very low. With stent now there's a very fast flow inside, and even for the extravasation. The first one seems to have an aspect like a pseudoaneurysm, and nothing happened. I have many cases with the pseudoaneurysm after superior predilatation. In a week it's disappeared. The second one still seems to have a bleeding, so active bleeding. No, I don't seem to have an hematoma. Something very, very small. There is no a big bleeding. However, I think at least with external compression and without heparin, it will close.
Usually the pressure you put in place is 100 or
It's depend on the pressure, on the systemic pressure. But here we can put 100 without any problem, because the most important thing is do not be occlusive with the artery. But here with the stent I don't think so we will be occlusive.
PB ได้ไหม
เดี๋ยวเราเอ็กขูดไอ้นี่ออกก่อนเราไม่สเตอร์ไลน์ก็ได้นะ The problem now we don't have the sterile
The sterile one.
Excuse me, if the bleeding is bigger than this, then you cannot stop the bleeding by.
Well, usually with external compression we can stop it, because at least what happens is that the bleeding increment the hematoma till it's autocompressive. So at least when I'm able to manage with the cuff, I let the cuff for 30 minutes, half hour, and then do a Doppler. Yes. How long it was for? Arrive to 7 or 8. Increase the time.
ไม่เยอะแต่ว่าก็ significant อย่างเนี้ยเขาให้7 แบบนะ
Increase the pressure of the balloon. How much time?
6:20.
Okay, arrive to 8 and check again. Give me contrast, please. Thank you. One minute more and stop. $7:30. No so patient. I'm not so patient. Still small bleeding. The proximal one is pseudoaneurysm, is an ectatic artery. I think for the second one we can control suddenly with external compression, because otherwise we risk to have an acute occlusion if we continue dilating the stent, and I want to avoid it. That's a arterial wall crack. Yes, it's not a big bleeding, so I don't think we need a cover stent. we must compress. We are there in the second well. Give me another contrast, please. Let me check the foot distally. Can you oblique in my way, please? Okay, a little bit down. Okay, nice. Perfect. The foot is fantastic. There's no more spasm. Yes, probably residual stenosis in the lateral plantar, but look, the blush in the wound place. The below the knee is perfect. The problem is just to the side. Can you oblique in the opposite side, please? Seems to wash, so I mean seems to have a very small bleeding because nothing remained there. The contrast went out. Remove the balloon without push the guide wire. Okay, it's enough. Yes, very small, very low. I think external compressor should be good. If you want, you can maintain the sheath, washing it, do the compression, then check, or otherwise close everything. It will be close. It's close. It's very close to be close. If probably if we wait another 15 minutes, it is closed for itself because there is no high pressure inside. It seems like two broken collateral. It's very thin. No high pressure. The proximal one is a pseudoaneurysm. Nothing happened with this. The second one probably will become another small pseudoaneurysm.
You cannot check the iliac?
The iliac, yes, we can check, but if you remember the
Not too much?
this iliac, I think so. No, we saw it from the beginning. Can you go up, please?
Go up. Go. Okay.
A little bit more.
Oh, okay.
Okay. Okay. I move the table. Oh, come on, it washed suddenly. There's a plaque there, but nothing significant. What do you think? You want to check in another projection?
Yeah. This way or
On the opposite one?
อีกครับสัก10-20ขอแอปเนียหน่อยนะครับ
โ No, no,
Not too bad.
not too bad.
Just
No, no, definitively doesn't need stent, I think. Maybe in the future, if she will have progression of the disease, but today seems good. Seems more than acceptable. Even the common with the supera perform properly well. Let me do the last check in the SFA, just to have an idea. Till now, this is everything. Can I touch?
yeah.
It's just to feel the pulse. No, I can't feel it. I will check. Yes, still there is a small bleeding, but very, very small. It's difficult to understand because if the bleeding usually remain there and there is nothing fixing after we contrast, so maybe finishing a vein, I don't know. However, external compression I think will be more than enough. You want to maintain it or not? No, sure. Perfect. I'm very bad feeling the pulse, man.
Maybe the calcium.
Yes. Try here. Maybe you can find it.
No, I can't. Can't feel.
You can.
Yeah.
It is.
Yeah.
Your hands are better than mine.
Do you?
Yes. Yes. Oh. Well, it's not the best one, but it's good.
Yeah. Because before the intervention, we cannot.
Feel any pulse?
Yeah.
Probably even the posterior tibial is patent. Well,
But it's supposed
what
to
are you
be
thinking? What are you thinking
be
about
here.
to do it here? What? So ulcerectomy? She needs surgery for this ulcer or not?
Yeah, yeah.
Yes, of
Maybe
course.
Tomorrow I will look at the
Okay.
intervention. Yeah. Okay. Thank you.
Do you want to put the cuff under fluoroscopy in the way to put it in the proper way?
That's fine.
Yes, a little bit.
Maybe here. I think.
No, this place look is. I think that's perfect. Yes, if you put up and down, so this is the center.
Center.
Exactly.
Thank you.
Okay.
Well done.
More difficult than I expected.
น้ำพริกแคทแลตเหรอ
ก็เลยจะทำที่เราทำแค่นั้น ผมไม่ทำเราเรื่องผมว่าฟูหรอจริงเราอยากทำเหรอถ้าอยากทำก็ทำเป็นผมเฟล2 ครั้งอาจจะไม่รู้นะครับอาจจะ8 จะได้4คุยกับพี่มัน
Thank you. What happened?
ขอบคุณค่ะ
Do you need an angioplasty too?
แม่ขอบคุณค่ะเจ็บเลยพี่แอน
อะไรอ่ะ
วัคซีนค่ะ
Well,
ready vaccine
ah, Dio santo.